Welcome to the CME program titled New Guidance to Treat Tumor-Induced Osteomalacia. This program is supported by an educational grant from Kyowa Kirin. I'd now like to turn the program over to our faculty educator, Dr. Aliya Khan of McMaster University.
Hello, everybody. My name is Aliya Khan. I'm a clinical professor of medicine at McMaster University, and it really is my pleasure to speak to you today about new guidance to treat tumor-induced osteomalacia. And these are my disclosures. I wanted to say that we recently published global guidance for the recognition, diagnosis, and management of tumor-induced osteomalacia in 2022. And I'll begin with a case. So I wanted to present a case of a 55-year-old man who came to our clinic, and he had been feeling weak and generally not well. And what was really quite striking was the muscle weakness that he noticed. And he was also having knee pains and pain in his hips and his feet. When he first came, the first assessment that he came, he was actually using a cane for support. And a month later, he came using a walker. And then after that, he came using a wheelchair. So within a course of 2 to 3 months, he went from a cane to a wheelchair. So the muscle weakness can be quite dramatic, and it can be quite progressive and significant over a short time period. Now, what is tumor-induced osteomalacia? It is a rare condition. It's a paraneoplastic condition, and it's associated with an increase in FGF23 being secreted by mesenchymal tumors. These tumors are usually benign, but they can be anywhere in the body. They can be small. They can be difficult to locate. Tumor-induced osteomalacia has also been reported in individuals with advanced metastatic cancer, such as colon and prostate. It results in significant muscle weakness, bone pain, and fractures. These are the typical presenting symptoms. And there is usually a delay in diagnosis, often for several years, because people are not checking phosphate. So if we don't check phosphate and we have a patient with muscle weakness and bone pain, patients may have the vitamin D levels checked. They might check 25D, which is usually normal. And so the diagnosis may be completely missed. So one of the important points that we wanted to highlight in this recent publication, and has been highlighted in other publications as well, is the importance of checking phosphate in people who present with muscle weakness and bone pain. So remember, we have a phosphaturic mesenchymal tumor, which can release FGF23. FGF23, fibroblast growth factor 23. And this is a hormone which will decrease the sodium phosphate cotransporters in the kidney and thereby decrease phosphate reabsorption in the proximal renal tubules. And so we have a renal phosphate leak. It also decreases the 1-alpha hydroxylase activity. And so the formation of 125D is decreased, and it increases the 24-hydroxylase activity so that catabolism is increased. And so we have a reduction in 125-dihydroxyvitamin D levels, and that will decrease the absorption of both calcium and phosphate from the bowel. And both of these effects, the renal effects and the GI effects, result in a decrease in serum phosphate. Now, calcium and phosphate binds to the osteoid to form normal bone mineralization, to allow that bone to mineralize. And so if the calcium phosphate product is abnormal due to inadequate levels of phosphate, then we will not be able to mineralize the bone, and we will have osteomalacia. We can have bone pain, fractures, and significant muscle weakness. So how do we treat it? Well, there is medical and surgical intervention. If we identify the tumor, we should definitely proceed with surgery. But usually we need to implement medical therapy right away because these patients do have significant hypophosphatemia. So conventional therapy consists of phosphate and active vitamin D. And phosphate needs to be given multiple times during the day because it has a short half-life. And it's important to remember that when we give phosphate, it can increase PTH, as we've mentioned. And phosphate can increase ectopic calcification. So we never want phosphate levels to be high. We also want to ensure that the risk of nephrocalcinosis is not increased by ensuring that we're not giving excess phosphate. Calcitriol can be given as well. Calcitriol is twice as potent as alpha calcidol. And you can begin at 0.25 micrograms. If the hypophosphatemia is mild, just give it 2 or 3 times a week. Or you could then go to 0.25 micrograms once a day or 0.25 micrograms twice a day. It does have a short half-life, 6 to 8 hours. So BID dosing is optimal if the requirement is more than 0.25 micrograms a day. And because the half-life is short, remember steady state is achieved in 5 to 6 half-lives. And so check the levels of phosphate, in 3 days. You don't need to wait 3 months to check it again. You might overshoot or undershoot. So check that level in 3 days. And if we give alpha calcidol or calcitriol, this can also increase FGF23 and increase the risk of nephrocalcinosis. Phosphate and calcitriol do have GI side effects, and it is important for us to recognize that giving back phosphate will further stimulate the parathyroid glands and increase PTH synthesis and secretion. So the medical management consists of oral phosphates, salts, plus active vitamin D, and we can also give burosumab. So if it's not a mild leak, our patient may require high doses of active vitamin D and phosphate salts and might not be able to tolerate them. And we will then switch over to burosumab. We do not give phosphate and active vitamin D with burosumab. We would switch. And then on burosumab, we need to monitor our patients carefully every 3 to 4 months, checking their serum and urine calcium, their serum phosphate, and obviously the urine phosphate as well, because we want to ensure that we're monitoring TMP-GFR. We need to monitor their renal function, parathyroid hormone, and the alkaline phosphatase levels. And every few years, we do recommend monitoring the kidney with renal ultrasound, ensure that we don't have nephrocalcinosis or nephrolithiasis. And we would also be doing imaging to determine if we are able to localize a tumor. Now, another medical option that is value in patients with tumor-induced osteomalacia is cinacalcet. Now, this is a schematic illustration of the chief cell in the parathyroid glands. And calcium binds to the calcium sensing receptor and decreases the synthesis and secretion of PTH. Now, if we have a patient with tumor-induced osteomalacia who has developed secondary or tertiary hyperparathyroidism, then we need to consider the fact that we might be able to reduce PTH synthesis and secretion by giving a positive allosteric modulator of the calcium sensing receptor. And cinacalcet is a positive allosteric modulator. It increases the sensitivity of the calcium sensing receptor to calcium, and it lowers the threshold for calcium to decrease PTH. This is the phase 3 double-blind randomized controlled trial study that we did in primary hyperparathyroidism. And we started the dose of cinacalcet at 30 milligrams twice a day and increased it to a maximum of 90 milligrams 3 times a day. The important point to note is that this study was done in patients with primary hyperparathyroidism, and we need to have a similar study in tumor-induced osteomalacia. But clearly, the drug is effective and it decreases PTH. And what it will do is, because PTH is coming down, we are now able to reabsorb phosphate through the kidney, and phosphate levels rise, and the TMP-GFR will improve. So the only way that we can improve the TMP-GFR is with burosumab. This is what burosumab does, is it binds FGF23. And so because it will bind to FGF23, it will result in an increase in the 1-alpha hydroxylation, and it will normalize 125D levels. It will normalize the calcium and phosphate absorption from the bowel, and it will increase the expression of the sodium phosphate cotransporters and allow sodium phosphate cotransporters to be expressed abundantly, and phosphate reabsorption through the kidney will normalize. So how do we treat it? Non-surgically, phosphate salts and active vitamin D. And we recognize that cinacalcid is a calcium mimetic agent that decreases PTH, but it requires further study in tumor-induced osteomalacia. Burosumab is the only FDA-approved therapy for tumor-induced osteomalacia. So burosumab was demonstrated to improve bone mineralization with reductions in osteoid volume over bone volume and osteoid thickness, as you can see. There was a reduction in the mineralization lag time and in the osteoid surface over bone surface. Fracture healing also improved with tumor-induced osteomalacia. To proceed with burosumab therapy, we will be closely following these individuals. If we identify the tumor, then we can go ahead with surgery, because surgery is curative. And while they're having their surgery, we would follow them and ensure that we're monitoring the lab profile every 3 to 4 months, measuring phosphate, serum, and urine, and also look at urine calcium and serum calcium. Once we have the diagnosis of tumor-induced osteomalacia, we do functional imaging and also proceed with anatomical imaging with MRI and CT. And we can use gallium-based functional imaging with PET or PET-CT gallium dotatate scanning, or copper-based PET-CT. And these are very useful and definitely a value over the octreotide scan. So the treatment is to initiate medical therapy with oral phosphate salts plus active vitamin D. Once we've got the diagnosis, we want to completely resect the tumor and ensure that we have tumor-free margins for ideal response if we want to reduce the risk of recurrence. And in patients with confirmed TIO, with unresectable, or we didn't find the tumor, we should proceed with oral phosphate salts plus active vitamin D or burosumab. It's not and, it's or. Okay, so we do recommend following these people every 3 to 4 months, and we recommend that for patients with unresectable tumors that have been identified on imaging, that they be followed every 1 to 2 years. Now, remember, tumors can recur. And we had a patient, this patient that I presented, actually, he did have recurrence. And so it's very important to get complete tumor removal with wide resection margins. In our patient, we actually had a tumor in the ethmoid sinus, and it did recur. So these tumors can be in very difficult locations, and they can have recurrence. And treatment can result in significant improvements in quality of life, muscle weakness, fatigue, and bone pain. So it's definitely going to make a big difference in our patients' management. So to just end with some clinical pearls, tumor-induced osteomalacia is a very rare condition. New guidance is available in our international paper. The key factor is we need to identify and diagnose tumor-induced osteomalacia to raise awareness amongst physicians that they should be checking phosphate, especially in patients who have weakness and unexplained bone or muscle pain. And think about it in patients in whom we have symptoms that are out of keeping with the clinical picture. Surgical and non-surgical treatment options are available, and quality of life is poor in these patients. We do need to improve our understanding of tumor-induced osteomalacia and standardization of the patient pathway, as well as the diagnostic assays and treatment modalities. And we expect to improve the outcomes in the near future. And so with that, I'd like to thank you for your attention, and I hope you enjoyed the program.